I really don't want to be the bad guy.
Well, I understand. I mean, nobody wants to be the bad guy. I understand what you're saying. But you have to think about it this way. We're really doing her a disservice by allowing her to go around behaving the way that she is and thinking that it's okay. This is a teaching opportunity. Now, what's important to remember is that you break bad news every day to your patients, but you do it in a caring and compassionate way. You do it because you're concerned about them. You're not the bad guy, are you? Do you see yourself as the bad guy? Okay, it's the same situation here. Well, take that same approach, sit down with her, tell her what she's doing wrong, tell her what she needs to do to correct it, and let her know what will happen if she does or if she doesn't correct the problem. So as a matter of fact, my suggestion is when you start the interaction, preface it with the comments that, look, you know, the reason I'm talking to you is because this problem has come to my attention. I care about you. I want to see you improve. Let's talk about the problem, and let's see what we can do to work it out.
Really, I don't want to upset her.
Well, she's going to be upset. The question is, how upset will she become? Because it is hard to hear criticism. It's tough. No one likes to hear it. But the important thing to remember and to repeat to her is that you care about her and you care about her performing well. You want her to improve.
I don't want to make a big deal out of it.
Well, the practice of medicine is a big deal. I think it's important that we keep it that way. We need to let the residents know that this is a very serious situation and we expect their performance to meet our standards. The other thing to keep in mind is that these problems, if they're addressed early on, we can avoid the big problems later down the road.
I don't want to ruin her career or life.
Well, you're right. I mean, this is a tough situation. But you got to remember one thing. We have a responsibility to the public to ensure that when someone completes our program, that they have completed all of the requirements and met all of our standards. It's the resident's performance. It's her performance that we're talking about. We're not ruining anybody's life or anybody's career. We're trying to uphold our standards. You need to point out the mistakes that she's made and the ways that she needs to improve those mistakes or correct the problem. On the other hand, think of it this way. You're giving her the opportunity to correct those problems or to modify those behaviors. That's what feedback's all about. I say it again. This is a teaching opportunity. It's just like any other situation. Some people, despite their best efforts and despite our best efforts, they may fail. So don't think of it as much as ruining her life or ruining her career, as much as upholding the standards that we set forth for her and for all the residents in our training programs.
I'm not sure how she will react.
Well, I think you do. We can expect her to be angry or to be upset. What we don't know is how upset or how angry she may become. The important thing to remember is when you break the bad news, state it very clearly, specifically, and in concrete terms. State what needs to be done to correct the problem and what the consequences will be if it's corrected or if it's not corrected. Now, in some cases, the person may overreact and you may feel that they present a problem to themselves or to others. And if that's the case, then we have a more serious problem that we need to investigate.
It's not so simple. I may have contributed to this problem.
Believe me, the only way you can contribute to the problem is to ignore it. You let it go on. Your job, our job, is to deal with it, whatever it is, and not sweep it under the carpet. Many of these big problems started out as little problems, and we all contributed to the big problem because we didn't deal with it when it was a little problem.
Oh, I'm sure she'll recognize the problem and not let it happen again.
Well, I'd like to believe you, but you know as well as I do. Hoping, wishing, thinking it's going to go away. Things really resolve themselves spontaneously. Really, the only way to bring about a resolution to the problem is to bring it to the resident's attention and to work with her to resolve it and to correct whatever needs to be done.
I think it's too late. She's too far along in the program.
Well, you know, I've heard that too, but let's think about it this way. The resident is here for a short period of time before they embark on a 30 to 40-year career. And we also know that if a resident has a problem and it's not addressed during their training, they carry that problem into their practices and they don't resolve them spontaneously. We really owe it to this resident, no matter what time it is, to sit down with her and go over the problem and look for ways that she can correct the problem. I like to think of it this way. It's never too late to help someone improve.
I don't like confrontation or to be confrontational.
Then don't think of it as a confrontation. Think of it as a teaching opportunity. It's the time to point out the problem, to help the person correct the problem, and if you get in the habit of correcting mistakes, residents will realize that this is part of your job. That's what educators do. If you do it regularly, even attack the tiniest problem or the seemingly insignificant infraction, what you will do is avoid the big problems down the road. It is going to be difficult, as we said before. You can expect the person to be upset. You can expect the person to deny the problem. That should not prevent you from meeting with the person. Have your strategies prepared, anticipate their reactions, and respond in an effective manner. Keep it focused on their resolution of the problem.
I don't want to end up in court.
Well, that's a legitimate concern, and I understand that. But keep this in mind. You see patients every day, knowing that any one of them is a potential litigant. But that doesn't stop you from practicing good medicine, and in the same way, it shouldn't stop you from being an effective educator. As a matter of fact, that's all the more reason that we need to follow our protocols and procedures that we have in place for dealing with residents who have difficulty. These procedures are both educationally sound and legally defendable. Also, there's an educational program available to help you deal with these problematic situations. Now, take, for example, the LIFE program. It gives you suggestions, techniques, strategies to deal with situations like this. Remember, you're not alone in this matter. Don't hesitate to contact me, the DIO, or our legal department. If you have any questions or concerns, we're here to assist you. Each time you go through it, it gets a little bit easier. A lot of this is in your mental attitude toward what you're doing. You need to give yourself permission to act. Another thing, these encounters will be stressful, some more than others. When emotions run high, you need to be extra careful to maintain your composure and communicate in a compassionate and caring way. You don't need to be a bully. It's just like breaking bad news to a patient. You do that every day. You do it in a caring and compassionate way because you're concerned. Take that same approach to dealing with a resident who's having difficulty. The legal system expects the medical profession to establish the standards and to ensure that residents have met those standards. That's our responsibility. We can defend our actions and know that we gave the resident every opportunity to correct his or her mistakes and to be able to show and to document that we were fair to the resident. Okay?
Hang on. Who said so? When? I can probably explain the whole thing. Are you sure they meant me? Other residents do that. No, I didn't do that. I'm sure it's not me.
Look, I've been waiting for over 10 minutes for you to get that patient placed in a room and ready for an exam. What have you been doing?
Well, there were no rooms. I had to wait.
Did you do anything around here other than make excuses?
Dr. Pinter, the patient, she'll hear you.
Well, maybe she should hear me. I mean, she should know that somebody around here cares that she's been waiting. I mean, what, you think she views you as a model for efficiency?
Okay, so tell me, what am I supposed to do when I see something that needs to get done and nobody seems to be doing it? What about these nurses who aren't doing their jobs? Why do I get blamed? I'm the one trying to see that patients get good care. Why should I be worried about hurting a nurse's feelings? And what about the welfare of my patients? Who's going to stick up for them? I think you've got this backwards, buddy. It's not me you should be talking to. It's that nurse who isn't pulling her own weight. They should do what they're supposed to do without having to be told.
Please, just one more time. I won't ask you again.
Well, that's what you said last time. Look, you've been on hydrocodone for, what? I mean, at least a couple of months now, that I know of. I mean, this is a very addictive painkiller. I mean, I don't have to tell you this.
Just one more time, Jessica. I promise, just one more time. I can handle this, but I can't make it through without some help. Please, Jessica, I'm dealing with it. There's no problem. Believe me, I can handle it. For God's sakes, come on, I'm a doctor.
What about the lab tests, the blood work?
CBC, let's see, white blood count 15.50, 72 segs, 7 bands. The urinalysis, on admission it was 10 to 15 WBC, 0 to 5 RBC, no bacteria.
Those are the admission tests. What about this morning's? I think if you'd examine the lab test, you realize that you're giving us all results. What about today's?
Ideally, after watching this segment of the LIFE program, you should be able to identify barriers to honest, productive communication and describe what I call the common traps of the evaluation process. You should also be able to enumerate ways to avoid them and to name the 5 stages of a learner's reaction to critical or negative feedback. You should also be able to list strategies that can help you deal with these reactions. And finally, by the end of this program, you should be able to explain the following paradoxical statement about any interaction that you have with a, quote, difficult learner. If it went smoothly, then it did not go well. This happens when we compare an individual's performance to how we performed in the same situation instead of comparing it to the established standards. The result is that we can end up accepting unsatisfactory performance or more often excusing away inappropriate behavior. Your position carries with it certain responsibilities, and one of them is demanding excellence and judging the performance necessary to achieve it. When you accept the position, you have to accept the responsibility. This trap is set when an individual is able to turn the tables on us and shift the responsibility for his or her actions onto others or onto you. For example, when a learner asks, "Why are you picking on me?" or "Why are you giving me this grade or score?" he or she has successfully managed to make their problem your problem. Counter this by using clear and instructive feedback about the mistake or mistakes they made, the behavior, focus on the problem at hand, and what needs to be done to correct it. We set this trap for ourselves when we fail to follow objective, established criteria, and we tend to focus on other extraneous factors as the basis for making our decisions. For example, a resident has failed to meet a performance standard, and someone rushes to the resident's defense by stating, "Well, you know, she's trying real hard." Or say you're dealing with a really chronic substandard performer, and you're thinking about dismissing this resident. You'll find somebody trying to shield him by coming to his defense and saying, "Well, you know, he really is a nice fellow." That's fine. He probably is a nice fellow and will always be a nice fellow. However, he may be one without a medical license. On the other side of this coin is the situation where the resident determines what the criteria should be. For example, a resident has experienced performance problems toward the end of the training program. In his effort to correct the problem, he says, "Well, I have a job lined up. I can't extend my training program." Well, this is not the criteria by which we determine whether the resident passes or fails. It's not up to the resident to determine the criteria. It's up to us as faculty and program directors to establish the criteria and to stick to it. Evaluating complex skills or complex behaviors requires multiple approaches. One instrument or one incident will not be sufficient. We need more than, say, rating forms to evaluate clinical performance. Use a number of different tools or approaches. The halo effect occurs when we consider people are capable in one or two categories and we're tempted to think they're capable across the board. We're often willing to excuse poor performance in one area because of excellence in others. This is known as the positive halo effect. The opposite also holds true. If we think somebody is having difficulty in mastering one skill, we might assume the same difficulty occurs in mastering others. This is the negative halo effect. For example, say you've got a really smart resident, really on his toes academically. If the halo effect is operating, you just might be willing to overlook poor work habits or sloppy charting. The opposite situation occurs when a resident is stigmatized for the rest of his residency training simply because of a single reprimand that occurred early in his career. Counter the negative and positive halo effects by focusing on the performance, not the past and not the person. Sometimes we decide to give an individual or a particular group special treatment. When we do this, we arbitrarily change the standards or the evaluation procedure. Inadvertently, obstacles arise in the evaluation process because the resident may not fall within recognizable domains, so the rules or the criteria no longer apply. One of the best examples of this is what I call NOMR, N-O-M-R, not our or my resident. Well, we've just legislated him or her out of our jurisdiction. You need to counter this one by being fair, firm, and positive. And remember, each day in the training program is equally important. No one day is any less or more important than any other. Be consistent and be fair. Keep in mind that you are about to deliver a reprimand or reprimands and they cause pain. Expect highly emotional reactions. In fact, if you think of the Kubler-Ross stages that patients go through when they get bad news, or modifications of it, you'll be well armed. You can expect a challenge, so be prepared for it. This is why I say, if the interaction went smoothly, then it did not go well. Once you deliver the reprimand, expect denial. It's a normal response to pain. Say you call a resident in to criticize her interaction with one of the nurses. Be prepared for her to disown the whole episode. The process is pretty consistent. After denial, you can expect anger. The strategy for handling denial is very precise. Describe the problem in specific, concrete terms. Then, describe what must be done to correct the problem. Finally, describe the consequences if the problem is corrected and the consequences if the problem is not corrected. Remember to maintain your composure, even if you get flustered, and be sure to monitor your frustration level, because you will often find your frustration level rising with the degree of denial. At that time, you may require a timeout. If you do, take it. Then again, you may want to reschedule another meeting or just take a break for a couple of hours. As far as handling anger, understand that it's inner focused and outer directed. Don't take it personally. Keep your cool. Realize that once you break down the person's denial wall, you're going to be dealing with a frustrated individual who's angry or upset. Do acknowledge the feelings, but not the validity of their comments. Remark on the fact that it's okay to be angry or upset, but don't respond to accusations or other comments. Don't bite the bait. Stay focused on improving performance. Above all, resist the tendency to feel like you have to justify your position or respond to accusations. You may find it very helpful to repeat the strategy that you used in stage 1, and that is describe the problem, describe the corrective steps that are necessary, and describe the consequences. You may find yourself doing that several times. Keep doing it until the message penetrates through that denial wall. If you get through these first two stages, the resident should show you some sign of understanding the nature of the problem and the steps necessary to correct it. It's critical at this point that you ask the resident to tell you in his or her own words what the problem is, what needs to be done to correct it, and what the consequences are if it is or is not corrected. Please do not ask, do you know what the problem is, or do you know what it is that you have to do? Get him or her to repeat back to you what you've said for clarification and, most importantly, for ownership. Having the person tell you what they need to do gives them ownership of the problem. At this point, when they realize they're in difficulty, some people may revert back to the denial stage and start to lash out. They realize they're in a bad spot. If that occurs, repeat the step 1, 2, and 3 of the denial stage, the problem, the corrective steps, and the consequences. As the person describes them back to you, you may find it helpful to write down those remarks. This will serve as a record of the interaction and as a reference point for the future. It's critical in cases where there are major problems or chronic problems. When you get to the fourth stage, bargaining, and the person recognizes and accepts responsibility for the problem, he or she may try to negotiate different corrective steps or different consequences. It's the old, well, what if I, and fill in the blank. Work harder, stop drinking, give up the hydrocodone, promise to eat better, whatever the case may be. Don't feel you have to negotiate. But if you do feel that you can negotiate, remember, only negotiate the changes that are within your control or under your authority. If you're not sure if you can change something, just say, I'm not sure I can do that. I need to check with so-and-so, and I'll get back to you. Also, don't deviate from the information you presented during the first stage, unless you have the power or authority to do so. Now we get to the last stage, acceptance or agreement. If you are successful in reaching it, you should conclude the meeting with an agreement that acknowledges the validity of the problem, the corrective steps, and the consequences, of course with any modifications that may have been made during the bargaining stage. A follow-up meeting should also be scheduled with the resident to confirm that a plan is in place and corrective actions have been taken. The seriousness of the situation is an indicator of whether or not a written agreement should be generated and signed by both parties. This simply means that the higher the stakes, the greater the need for written documentation. In situations where there's a chronic, ongoing problem, this calls for a formal academic remediation plan. Take care of a problem when it happens. Jump all over it. Try to do away with it before it becomes one that calls for radical measures. Just remember, it's not easy to confront residents, to reprimand or correct them. Nobody likes to do it. Nobody likes to be on the receiving end either. It might be easier to avoid doing it than it is to do it. That's true. There certainly is no penalty if we don't do it. But as good educators, it's our job to point out mistakes or inappropriate behaviors. There's another thing. Sometimes, despite all of our best efforts to help someone improve or correct their deficiencies, even when they try their best, they give it their all, sometimes that just isn't good enough. When that happens, when someone fails to meet the standards we've set, it's our job to dismiss them or to allow them to resign from the program. It's tough. And finally, remember this. We're not obligated to graduate every resident. We are obligated to graduate competent residents. That's our job. That's our responsibility. To the residents, to the medical profession, and most importantly, to the public. The clips you have just seen from the LIFE program illustrate several types of problems that either faculty or program directors see on a fairly regular basis. These programs not only show you different situations that might occur, but they also demonstrate how they might best be handled. However, if giving negative feedback or providing criticism to our residents or learners were as easy as it looks on film, I wouldn't be talking with you today. All too often, educators tend to ignore, minimize, or excuse inappropriate behavior or mistakes. Why? Because it's uncomfortable having to confront people whose performance is substandard. Most of us tend to avoid conflict if we can. But avoidance only compounds the problem because it postpones what is really called for, either remediation or, if it becomes necessary, dismissal. I'm here to provide you with a few techniques that will help you handle the emotional aspects of situations like these, situations that require confrontation, which, as we all know, can be very stressful.